we will move on to the next important topic, osteochondroma. Okay, this is otherwise called exostosis. This is otherwise called exostosis. The point I want to tell, this is a rapid revision session. No, so in detail I had done it in my main recording. The thing just I want to stress, this is the most common primary benign bone tumor. Okay, this is the most common primary benign bone tumor. Okay, so this is the point I want to stress. Most common primary benign bone tumor. It is, what is osteochondroma? It's an offshoot from the spongy tissue covered with a cartilaginous cap. That's why the word chondroma. This is, to be very frank, this is not a pure bone tumor. This is of cartilaginous origin. Okay, not purely from bone tissue, cartilaginous origin. And the most common age, it is during growth period. Okay, growth period, say around 13 to 20 years. This is a very common growth during growth period, more common in males. And the most common site is lower end of femur. It is the most common site. It is lower end of femur. This is the most common site, lower end of femur. That's the most common site. The second common site is upper end of tibia. Upper end of tibia. So, in nutshell, most common site is around knee joint. Around knee joint. Okay. So, that's the most common site. Most commonly, it happens in males. It's more in males than females. Very common during puberty, that is during growth period. So, the age usually around 16 years, 13 years to 20 years. And as usual, no, I had stressed much earlier in our regular recording, I had stressed that whenever you are reading a bone tumor, you should know whether it's originating from epiphysis, metaphysis or diaphysis. So, this arises from metaphysis. Okay. Osteochondroma, otherwise called exostosis, arises from metaphysis. Chondroblastoma, epiphysis. Osteogenic sarcoma, metaphysis. Ewing sarcoma, diaphysis. Giant cell tumor, otherwise called osteoclastoma, epiphysis. Guaranteed you will get a question, okay, from where it is originating. So, osteochondroma, otherwise called exostosis, arises from metaphysis. Usually, this is symptomless. Patient will have a pain-free or painless swelling around knee joint. That is the common presentation. Pain should not happen in exostosis. Okay, see the common sites around the knee joint, the lower end of femur, and next thing it is in the upper end of tibia. So, around knee joint, you see this, how this is composed. You see, this is the proper offshoot, the bone. This is the bone. Only this much is the bone. This big, no, this is a cartilaginous cap. That big is a cartilaginous cap. So, the point I want to stress here is, dear friends, concentrate here. See, that is why if you take an X-ray, the exostosis appears very small, only this much size. X-ray will show you only this much size. Because X-ray can detect only bone, yes or no? It can't detect the cartilage. But outside, this is surrounded by this big size cartilaginous cap is there. Only this is bone. This is bone. X-ray shows only this. The outer cartilaginous cap, X-ray won't show. That is why in X-ray, 99% of the exostosis appears very smaller. In real time, when you do a surgery, when you see, no, it appears much bigger. That's the reason. Okay. And you are not supposed to get pain in exostosis. When pain appears in exostosis, think of three situations. Number one, bursitis. Because it's surrounded by a cartilaginous cap, it's around the knee joint. We Indians, we used to sit cross-legged in the floor. Constant friction to the bony outgrowth. So, it will form an adventitious bursa. When the bursa gets inflamed, it's called bursitis, severe pain. That's the most common cause. Pain in exostosis is the most common cause. Rule out an adventitious bursitis. The second common thing that can happen, fracture. Exostosis can get fractured. Exostosis can get fractured. When exostosis get fractured, any fracture anywhere in the body, there will be pain. So, fracture is the second cause. The third cause, the rarest possible cause, is malignant change of osteochondroma. Osteochondroma becomes chondrosarcoma. Osteochondroma becomes chondrosarcoma. The chance is only 1%. Of malignant change of osteochondroma becoming chondrosarcoma is only 1%. When it goes for malignant transformation, two things happen. Sudden pain, without trauma, sudden pain, sudden increase in size. When exostosis, sudden pain, sudden increase in size, we should be very vigilant. We have to excise and send it for biopsy to rule out malignancy. So these are the three possibilities. One more possibility also I can add, dear friends. Pain in exostosis. Fourth thing can add here. Nerve compression. Okay. Nerve compression. When exostosis around knee joint, this goes and compresses the nerve, that can cause pain. Yes or no? So 4 causes of pain in exostosis. And in gross appearance, the exostosis, it gives what is called a cauliflower appearance. Asked question. Okay, so far what we have seen is exostosis. Treatment of exostosis is just excision is the treatment of choice. You have to excise the exostosis, send it for biopsy, make sure it is not malignant. So excision is the treatment of choice. You should understand one point. Exostosis is a pre-malignant condition. Whenever you are dealing with a pre-malignant condition in bone tumors, excision is the treatment of choice. You are excising a hollow thing can happen in the bone. You should not fill the hollowness with a cancellous bone grafting. Cancellous bone grafting is contraindicated in pre-cancerous condition. So excision is a treatment of choice. Okay. So far what we have dealt is simple exostosis or solitary exostosis. There is one more condition called hereditary multiple exostosis. This is a different condition. Hereditary multiple exostosis. Hereditary multiple exostosis is otherwise called diaphyseal achalasia. Asked question. So please read the question very carefully, then go for answers. Because hereditary multiple exostosis originates from diaphysis. Simple exostosis originates from metaphysis. That's the difference. And hereditary multiple exostosis is an autosomal dominant condition. Boy-girl ratio is equal. Simple exostosis is more common in boys. And here the distal ulna shows a tapering ulna, and that is called a carrot-shaped ulna. That's a carrot-shaped ulna. So one point I want to stress here: simple exostosis, metaphysis; hereditary multiple exostosis, diaphysis. Then we'll see the next important topic, osteogenic sarcoma. In detail, I have taken everything. Just I am giving an outline. That's all. This is rapid revision. Okay, it's an outline. It is the most common primary malignant bone tumor. 1 lakh time repeated MCQ. See, dear friends, once again I repeat. If they ask a question, most common bone tumors, no special prefix, no special suffix. If they ask an MCQ, most common bone tumors, answer is secondaries. Secondaries are more common than primary. Secondaries. Okay, right. If they ask a question, most common primary benign bone tumor, answer is exostosis or osteochondroma. If they ask a question, most common primary malignant bone tumor, osteogenic sarcoma. If they ask a question, most common primary bone tumor happening in elderly over 70 years, over 80 years, when they ask a question like that, answer is multiple myeloma. So 4 different answers are there, dear friends. Please concentrate. Most common bone tumors in general or secondaries. Most common primary benign bone tumor, osteochondroma. Most common primary malignant bone tumor, okay, it is osteogenic sarcoma. Most common primary malignant tumor happening in elderly, multiple myeloma. Please read the question very carefully, then go for an MCQ, because nowadays we are having negative markings. We should never make mistake in simple topics like this, straightforward topics. It arises from, osteogenic sarcoma arises from multifactorial mesenchymal tissue. It arises from multifactorial mesenchymal tissue. A most common age group is second decade. Very important. Okay, around 20 to 25 years. This is very common around this. This is the age. And in detail, I had given everything in the main recording. Kindly go through that. 90% of the tumors, osteogenic sarcoma, arises from metaphysis. Again, the most common site is around knee joint, that is distal femur, proximal tibia. Okay, lower end of femur is the first common site. Okay, and proximal tibia is the second common site. When you club together, it is around knee joint. And so far, they were telling that it is idiopathic, and no one knows how it is originating. One thing they had identified, Robin says, no, the chromosome that is involved is 13q14. That is the chromosome that's involved in osteogenic sarcoma. Aberration happens, mutation happens in 13q. Q means long arm, 13q14. The same chromosome we had read somewhere else. We had the same chromosome, we had read it in retinoblastoma. Okay, retinoblastoma, when you remember, no, the same chromosome. That is why this is called RB gene. This chromosome, this number is called RB gene. So that, Robbins very clearly says that those who have developed osteogenic sarcoma, high chance of developing retinoblastoma. Those who have developed retinoblastoma, high chance of developing osteogenic sarcoma. This question they had already asked in pathology. Okay, one of the following tumor is very common with retinoblastoma. This was the question, osteogenic sarcoma. Okay, so it's very simple. And you see, dear friends, most around knee joint. Now they had found out few predisposing factors. One is a polyoma virus, SV40 virus, and radiation given more than 2000. This is not rads, RADS, RADS. 2000 RADS and certain chemicals can cause predisposed osteogenic sarcoma, and they are methylclonanthrene, beryllium. Look at this, very, very peculiar. So far unasked in any of the Indian entrances, because we know asbestosis causes mesothelioma, silicosis causes coal workers, silicosis predisposes to tuberculosis, silicotuberculosis, occupational lung disorders, occupational hazards, asbestosis causes mesothelioma, silicosis predisposes tuberculosis. All these things we had seen. Okay, right, like that. Berylliosis causes osteogenic sarcoma. Pathologically, the tumor could be osteosclerotic or osteolytic, but the most common type is combination of osteosclerotic and osteolytic. A mixed type is the most common type. On gross, an osteogenic sarcoma on gross appearance gives a leg of mutton appearance, and on clinical presentation, the most important point, because nowadays it is clinically based questions. They are giving a big history, they are asking you to diagnose, otherwise they are showing an image and they are asking you to diagnose. If in a bone tumor case, bone tumor history or question, pain is the first symptom. Pain is the first symptom. Okay, right. Pain is the first symptom. Swelling is the second symptom. Swelling is the second symptom. Swelling is the second symptom. They are asking for osteogenic sarcoma. Osteogenic sarcoma, I am to tell you, dear friends, pain starts much earlier. No history of trauma, nothing, a vague pain around knee joint. In second decade of life, don't take it lightly. Please don't take it lightly. Pain is the first symptom. Swelling comes much later. Okay, why I am telling we should try to pick up osteogenic sarcoma as quick as possible, dear friends, because it is notorious to have secondary spread, hematogenous spread to lungs. Once secondaries has happened, prognosis is, it's you can't predict, very bad. Okay, prognosis is very bad. So you should try to pick up early and try to treat as early as possible. Then only we can give some 5-year survival rate. Something. Once secondaries has happened, in few months patients will pop away. Okay, so you should be very careful. Pain is the first symptom, swelling is the second symptom. Other way around, in giant cell tumor or osteoclastoma, swelling comes first, pain comes next. So whenever they're asking a question, or 25-year-old male patient had pain first, swelling second, the diagnosis mostly it should be osteogenic sarcoma. Swelling first, pain came late, it could be osteoclastoma, otherwise called giant cell tumor. Please register this in your mind. Coming to the radiological features of osteogenic sarcoma, hazy osteolytic area, alternating with dense osteoblastic, because osteosclerotic, osteolytic. Combination of osteosclerotic and osteolytic is the most common type. So hazy osteolytic areas will be there with dense osteoblastic area, alternating with dense osteoblastic. This usually you will get. Classical appearance, no, streaks of new bone radiating outwards from the cortex, which is called sunburst appearance, which is called sunburst. See, a very classical X-ray, a very classical X-ray of sunburst appearance. You look at here, you are able to see micro streaks. What could be the cause of sunburst appearance? You know, osteogenic sarcoma, whenever I use the word sarcoma, highly vascular tumor. Lot of blood vessels, no? For example, this is the main tumor mass. Blood vessel streaks like this. Blood vessel gets streaks like this. Okay. So blood vessels you can't see in the X-ray, but microcalcification happens around the blood vessel. Okay. Microcalcification happens around the blood vessel. These microcalcifications you are seeing here as sunburst appearance. Okay. So that is the, if you understand, no need to memorize. So that's a classical sunburst appearance. This is one finding. Second important thing you should note in a thing, no, periosteal elevation. You see, this is the cortex. This is the cortex. Okay. Right? That is the cortex. Okay. So here you see this is the cortex. When you carefully watch here, no, this is the periosteum. In one place, periosteum is lifted like this. Then it is going. Okay, so this is the inside cortex. A triangle is formed here. Elevation of the periosteum. Okay, you see, now you carefully see this. You can understand a triangle is formed here. So that is called Codman's triangle. Periosteal elevation caused by osteogenic sarcoma is called Codman's triangle. See, periosteal reaction or periosteal elevation happens in few situations. The most common cause for periosteal reaction or periosteal elevation is osteomyelitis. Number one. Second cause for periosteal elevation or periosteal thing is scurvy. Third cause for periosteal elevation is syphilis. Fourth cause for periosteal elevation is myositis ossificans. Fifth cause for periosteal elevation is osteogenic sarcoma. There are 5 differential diagnoses for elevation of periosteum, dear friends. In all the situation, X-ray appears only like this. Just elevation of the periosteum forming a triangle. I repeat once again, what are the 5 causes for periosteal elevation in orthopedics? Osteomyelitis, scurvy, syphilis, myositis ossificans and osteogenic sarcoma. But the word Codman's triangle is reserved only for periosteal elevation caused by osteogenic sarcoma. Other 4 causes, you are just telling it is periosteal elevation. You will never use the word Codman's triangle. It is like evening rise of temperature that happens in almost all fever. Viral fever, evening rise of temperature. Bacterial illness, anywhere except evening rise of temperature. But the word evening rise of temperature, we know it is reserved for tuberculosis. Like that, Codman's triangle is a word reserved for osteogenic sarcoma. Okay, so these are the X-ray findings. Then CT scan is superior to X-ray, but biopsy is confirmatory. Obviously, any bone tumor, best investigation is biopsy. Okay, yes. Secondary osteogenic sarcoma usually develop from Paget's disease. You should know. Okay, in the predisposing factor, polyoma virus, SV40 virus, we had seen in that you should add Paget's. It's a predisposing. 1% of Paget's patient can go for osteogenic sarcoma. Okay, and always what happens, no? Spread is through hematogenous blood spread, and the most common organ that's involved in the secondaries in osteogenic sarcoma, lungs. Okay, 10 lakh times repeated MCQ in our past 10 years NEET exam, All India NEET. Okay, most common organ that's affected in secondaries organ that's involved in osteogenic sarcoma, lungs. Okay, right. Treatment of osteogenic sarcoma, there is no doubt surgical. Surgical amputation is the mainstay, that no. But before that, no, you should give a course of chemotherapy. The agents that are used are methotrexate. Citrorofactor, factor, adriamycin. Okay, so methotrexate, you know it is an antimitotic agent. The main complication is bone marrow suppression. Adriamycin, Pharmacologist would have taught you the main complication is myocarditis, okay, cardiomyopathy, myocarditis. So you can try these agents. A latest treatment option, what aptly says is, just give a chemotherapy first, radiotherapy next, followed by surgery. This is called a combined approach. This is called a combined approach, okay. This is a combined approach. Give chemotherapy first, radiotherapy next, then do an amputation. Very clearly book says that this prevents recurrence. This prevents recurrence. Then pulmonary metastasis is best managed by chemotherapy, and the drug that is used is erlotinib. Erlotinib hydrochloride, okay. Erlotinib HCl hydrochloride is the drug of choice for pulmonary metastasis. And dear friends, I want to stress another important point here, and this is an ortho point and a Bayesian-Low point, okay. So this is one tumor where BCG vaccination can improve the immunological status. Improve the immunological status. It's not very peculiar. You see, when you give BCG vaccine, it raises the immunological status of the patient against this tumor, right? BCG vaccination. We all know we give BCG at birth to prevent tuberculosis. That every child, UKG baby knows that answer. BCG, where it's helpful, no? Two tumors, Bayesian-Low telling. One is osteogenic sarcoma. Another, everyone knows, very, very popular MCQ, bladder carcinoma. Bladder carcinoma, okay, bladder CA. The immunological status is raised by BCG. So BCG raises the immunological status in two carcinomas, osteogenic sarcoma, bladder carcinoma. Bayesian-Low, when you read, he has used the word intralesional BCG in bladder carcinoma. Intralesional BCG, when you give, it raises the immunological status. Then we'll move on to the next important tumor, no? Osteoclastoma. This is otherwise called giant cell tumor. This is otherwise called giant cell tumor, GCT. Okay, giant cell tumor, otherwise called osteoclastoma. Is it malignant or benign? This is a question. Most of the time it is benign, but it has malignant potential. It's malignant also because it behaves locally. It is malignant. Osteoclastoma is a benign tumor. Locally, it's malignant. It causes erosion, and secondaries have been reported in osteoclastoma. So it is both benign and malignant. 90% it should behave in a benign fashion. 10% it can behave like a malignant tumor. And as usual, osteogenic sarcoma arises from metaphysis. Giant cell tumor or osteoclastoma arises from epiphysis. Look at the age, 15 to 35. 15 to 35. Osteosarcoma happens little younger age. Most common site, again, it is lower end of femur and upper end of tibia, that's around the knee joint. Look at the next point. No pain, only swelling. In the beginning, there will be only swelling. I told you in the previous session, I told you osteoclastoma, the first presentation is swelling, pain develops later. Osteogenic sarcoma, pain comes first, swelling comes much later. On palpation, osteoclastoma gives a eggshell crackling sensation. Okay, eggshell crackling sensation. And the persistence of abundant, and dear friends, the close differential diagnosis for osteoclastoma giant cell tumor is bone cyst. Okay, bone cyst. This is the closest, and especially aneurysmal bone cyst. Aneurysmal bone cyst. This is the closest possible differential diagnosis for osteoclastoma, aneurysmal bone cyst, because in both aneurysmal bone cyst and osteoclastoma, radiologically it will show you an osteolytic lesion, just osteolysis. When you take a biopsy, when you take a fine needle aspiration cytology, when you see aneurysmal bone cyst and osteoclastoma, both will have multinucleated giant cell. Both will have multinucleated giant cell. Multinucleated giant cell. Multinucleated giant cell. This will be the thing. Multinucleated giant cell. Otherwise, you will have in histopathology multinucleated giant cell both in ABC and giant cell tumor. Then how to differentiate whether this is aneurysmal bone cyst or giant cell tumor? Unusual bone cyst is just a simple bone cyst. Very, no need to worry about malignancy and all. Okay. Whereas if it's a giant cell tumor, it can be malignant. Yes or no? So how to differentiate? You just aspirate and see. In the cytology, when you see only multinucleated giant cell, it could be giant cell tumor. Only multinucleated giant cell, it is giant cell tumor. When multinucleated giant cell here and there are having some hemosiderin with it, it could be aneurysmal bone cyst. It could be aneurysmal bone cyst because aneurysm means blood vessel. Blood vessel contains blood. Blood contains hemoglobin. Hemoglobin should contain hemosiderin. So you are seeing hemosiderin mixed with multinucleated giant cell. Diagnosis aneurysmal bone cyst. You are getting only multinucleated giant cell, not able to see single hemosiderin. It could be a giant cell tumor. Okay, that's all. And coming to the radiological feature of giant cell tumor, otherwise called osteoclastoma, cortex is expanded and thinned out. See the cortex. Here you see the cortex here, it is comparatively thick. Yes or no? You see here the cortex is thinned out, totally thin. See here, totally very thin. I will erase. You see the difference. Okay, totally see the cortex is thinned out. No periosteal reaction. If it is osteogenic sarcoma, there should be some periosteal reaction. No periosteal reaction. Then thin septa of bone, thin septa of bone traverses the interior and produce the classical soap bubble appearance. 10 lakh time repeated MCQ. See the classical soap bubble. Small bubbles. You see here. Okay, so classical soap bubble appearance. You see, now you watch classical soap bubble appearance. Diagnosis. Okay, it is osteoclastoma. And treatment of choice is surgical amputation is the treatment of choice. Moving on to the next important tumor, Ewing sarcoma. Ewing sarcoma arises from diaphysis. Osteogenic sarcoma arises from metaphysis. Giant cell tumor arises from epiphysis. Ewing sarcoma arises from diaphysis. And I told you in the main recording, Ewing sarcoma is a tumor that arises from the bone marrow cells. Then you may be wondering, bone marrow cells. Multiple myeloma is also a tumor which arises from bone marrow cells. Then what is the difference? Bone marrow cells has two types of cell. One is called an endothelial cell. Another is called a plasma cell. Okay, another is called a plasma cell. When tumor arises from endothelial cells of bone marrow, it is Ewing sarcoma. When tumor arises from plasma cell of bone marrow, it is multiple myeloma. That's the difference. Okay, right. So, Ewing sarcoma is a malignant bone tumor which arises from endothelial cells of bone marrow. And most common age is 10 to 20 years, males. Most common bone that's involved is tibia. This is very peculiar. So far we had seen the most common is lower end of femur. This is the first tumor you are seeing, most common upper end of tibia. Note this point. Okay, but anyhow it's around the knee joint. Histologically it shows pseudo-rosette and this is called Homer-Wright. Rosettes. Pseudo-rosette is called Homer-Wright rosette. Where you have read this? One more place. I'll count 3. Just think. I'll give you a clue. Robbins. 3, 2, 1. Homer-Wright or pseudo-rosette. Where you have seen? Neuroblastoma. Okay. Neuroblastoma. Pseudo-rosette, other called Homer-Wright rosette. Neuroblastoma, Ewing sarcoma. True rosette, other is called Flexner Intestinus rosette. Retinoblastoma, osteogenic sarcoma. So they can ask this as a question. Okay. Right. X-ray shows 3 classical appearances. One is called moth-eaten appearance of bone. Second is a cracked ice appearance of the bone. And the third one is called onion peel appearance of the bone. And this is more common than the other 2 types. Look at the classical, you see This is a real bone. A patient suffering from Ewing sarcoma. You are able to see the periosteum is divided into layers, man. You see, periosteum, multiple layers of periosteum compared with an onion peel. You're peeling an onion. Exactly, you can see multiple. That's an onion. You see multiple layers. Look at here. You closely you follow. How interesting is this? You see multiple stripes like things of periosteum, multi-layered periosteum, just giving an onion peel like appearance. Okay, onion peel appearance. Right. And differential diagnosis for onion peel appearance. One should be very careful. Onion peel appearance, when you see an X-ray like this, the first diagnosis is Ewing sarcoma. Second thing, this confusing guy, osteomyelitis. Periosteum, some changes there, no. Common cause is infection. Then only tumor comes, osteomyelitis. Then the third thing is malignant lymphoma. And this is one tumor, Ewing sarcoma is one tumor that highly radiosensitive. So the book says melts with radiation. But the treatment is surgery. You should give radiotherapy first. Just melt the tumor, then you can amputate. Recurrence is less. Okay. So then comes another important tumor, multiple myeloma. This is called plasmacytoma. This is the most common tumor in elderly. I told you in the very beginning, 7th decade and above. Microscopy shows spokes of wheel appearance and X-ray findings. Very, very classical X-ray findings are there. 3 or 4 important X-ray findings are there. One thing is called biconcave vertebra. This is other is called codfish. Some books uses the word codfish vertebra. Okay. Right. So biconcave vertebra, that's called codfish vertebra. Just I had given it for comparison. You see, a normal vertebra this much width is there and it's rectangle or little squarish or rectangle. This is a normal vertebra. You look at multiple myeloma vertebra. Yes or no? You see the difference. This is normal. Is it not looking biconcave like an RBC, biconcave, dumbbell, biconcave? And this is called a codfish vertebra. Okay. Biconcave vertebra or codfish vertebra. Very classical of multiple myeloma. Right. Then comes punched out lesions in the skull and pelvis. You see multiple small punched out lesions in the skull. And this is called raindrop skull. This is called a raindrop skull. Punched out lesions in the skull. What are the possibilities? Number 1, eosinophilic granuloma. Number 2, multiple myeloma. Okay, multiple myeloma. Number 3, gout. Please have this in your mind, dear friends. Okay, whenever a question punched out lesions in bone, they are asking a question. 3 things should cross your mind very immediately. Eosinophilic granuloma, which comes under histiocytosis X. Eosinophilic granuloma is one form. It's a benign tumor, eosinophilic granuloma. Second is called Hand-Schuller-Christian's disease. Third is called Letter-Suey syndrome. Mildest form of histiocytosis X is eosinophilic granuloma. Worst form of histiocytosis X is Letter-Suey syndrome. Okay, all these Robbins gives. So that is a cause for punched out lesion. Number 2, multiple myeloma. Number 3, gout. Okay, so these are the 3 differential diagnoses for punched out lesions of the skull. Then comes disappearing vertebra, otherwise called vanishing vertebra. Okay, disappearing vertebra or vanishing vertebra. You see here, right? You are able to see, this is a real picture. You just see this picture. You see here, you are able to see this big vertebra. Okay, here is there. Another vertebra is also seen here. In between, this is collapsed to such a small extent that you are not able to see the vertebra. Suddenly, it looks like a vertebra is disabled, able to count 1, 2, something is missing, 3, 4. So that is called a vanishing vertebra or disappearing vertebra. Then an important thing, pedicle sign. This is otherwise called winking owl sign. You take an X-ray very clearly, a beautiful picture I am giving. Just you see pedicles. You are able to see this is, see first I will draw, then I will erase that. Just follow. This is the shadow which you are seeing, spinous process. These are the pedicles. End on view. Okay. Spinous process, this is a pedicle. Spinous process, pedicle. Okay. So this looks like two eyes. Yes or no? This looks like, you see here, two eyes. Suddenly, here, one eye is missing. One pedicle is missing. Okay. As if an owl, no? One eye is winking the eyes, no? Closing the eyes, winking the eyes. One eye is open, one eye is closed. Is it not looking like that? So this is called a winking owl sign. Okay. Other is called a pedicle sign. Right. So very classical of multiple myeloma. Coming to treatment, chemotherapy is the treatment of choice. And the mnemonic which time-honored uses come: steroid, cyclophosphamide, urethane, melphalan. Melphalan, this is the drug of choice. That's why the trade name, it's coming as Myleron. Okay, Myleron. Multiple myeloma. So Myleron, others called melphalan. Right. So in multiple myeloma is dealt well by physicians. Once again, I'm telling you, chemotherapy can be tried, and if it's an early stage, no, you can do bone marrow transplant. BMT is another good option for multiple myeloma. Bone marrow, okay, transplant, right? So that completes multiple myeloma. Okay, dear friends, we will move on to the next topic, anterior cruciate ligament injury. See, you know, there are two cruciate ligaments, okay, one anterior from the femoral condyle to anterior aspect of the tibial plateau, tibial condyle, it is called anterior. Another from the condyle to the posterior aspect of the tibial, that's called posterior cruciate. This gives a cross-shaped, so it is called a cruciate ligament. That's called cruciate ligament. Okay. So what is the mechanism of injury? See, anatomy, all those things in detail I have taken the main recording. Kindly refer. The anatomy of ACL is very important. Since this is a rapid revision, I am going very fast. See, isolated ACL tear. Pure ACL tear happens because of four mechanisms. Number one, quick deceleration. Okay, a sprinter, a runner is running very fast. Suddenly he is stopping. No, that's called quick deceleration. ACL will be gone. Then hyperextension of knee. ACL will be gone. Rotation, for example, foot is fixed to the ground. Okay, and the leg is twisted. Usually football players will do that. That's called rotation injury. ACL may be gone. Then cutting actions. What do you mean by cutting actions? See, you are running in one direction very fast. You are running in one direction. Suddenly you are changing the direction. That is called cutting action. Very naturally, very normally, you would have seen this in National Geography or Animal Planet channel. A lion or a tiger chasing a deer. Deer will be moving in. Suddenly it will change the direction to distract the lion. That's called cutting action. Okay. So when we do that, no, ACL is more prone for injury. When knee joint, so these are the four mechanisms by which isolated ACL tear can happen. Whenever there is a combined injury, for example, a pedestrian is walking from the side, a two-wheeler had come and hit on the side lateral aspect of the knee joint. Apart from ACL, it can go for certain other injuries also. What are the common associations? See, when from the side, ACL will be gone, medial menisci will be gone, medial collateral ligament will be gone. This combination is called unhappy triad. This is a very favorite initiate question. Unhappy triad. Okay, it's called unhappy triad. Right. Other is called terrible triad. Terrible triad. So many names, and that goes by a name called Donoghure. Okay, it's pronounced as O'Donoghue. The correct pronunciation is O'Donoghue. Okay, so it's called O'Donoghue, unhappy triad. O'Donoghue. This is an Irish word. Okay, it's an Irish word. O'Donoghue. That's the correct pronunciation. So that's called terrible triad of knee or unhappy triad of knee. ACL plus MCL plus medial menisci. Okay. Patient, clinical history, falls to the ground. He couldn't get up immediately. He can't get up. Severe swelling, severe pain happens immediately. Then ACL is gone. I'll give another clue. Patient had fallen down gets up normally, continues to play for quite some time. Okay. Next day he is developing swelling and pain, meniscal injury. Meniscal injury will give you time. Cruciate ligament injury, no time. Immediately the patient can't get up and okay. So severe swelling. Severe swelling in the knee with few hours because of hemarthrosis. Right. Most patient gives history of giving away feeling, that is instability. Whenever I climb the stairs down, I am feeling a sort of giving away, instability. Okay. ACL is gone. While when the patient says that while climbing upstairs I am getting a giving away feeling, clinically it says posterior cruciate ligament. Climbing down the stairs, anterior cruciate ligament. Okay. Yes. And the clinical tests, two important clinical tests. One test is gold standard. Two tests are commonly employed. Third test is just for theoretical purpose. Okay. Commonly employed one test, anterior Droyer's test. What is that? Make the patient lie down in supine position. Look at the diagram. Supine position. Flex the hip to 45 degree. Flex the knee joint to 90 degree. The examiner sits on foot of the patient and catch by with your fingers crossed, just catch hold of the calf muscle. Just give an anterior translation. Just give an anterior translation. Just give an anterior translation. Right. So when you give an anterior translation, when anterior translation is more than 5 millimeters, when anterior translation is more than 5 millimeters, when anterior translation is more than 5 millimeters, it says the test is positive. Okay. So test is positive. What is that? Patient in supine position, knee flexed to 90 degree, examiner sits on the patient's foot, thumb and both hands on tibial tuberosity. This test is considered positive if there is soft end point, giving away just easily, it's getting translated more than 5 millimeters. It is positive. And the book says this is less accurate and less reliable than Latchman's test. This is less accurate and less reliable than Latchman's test. Okay. And you should know what is doorstep phenomena. Okay. It's an additional point for you. What do you mean by a doorstep phenomena? Doorstep, I don't know. All the books are giving the word doorstep. There is a word in English called doorstop, doorstopper. For example, just you are closing a flush door. When you put a stopper, after one particular point, the door won't go and close. It will stop at the level. That's called doorstop. So they are comparing with that. What do you mean by doorstep effect? If there is pure anterior cruciate ligament injury, Latchman test is easily positive. If there is pure anterior cruciate ligament injury, the anterior Droyer's test is easily positive. When anterior cruciate ligament injury is associated with posterior horn of medial meniscal injury, what happens? This posterior horn of medial meniscus goes and buckles, put a lock-like thing, so it won't allow the anterior translation of tibia. So, even though there is ACL injury, if there is associated posterior horn of medial meniscal injury, anterior Droyer's may be negative, false negative. That is called doorstep phenomena. That is why this is inferior, not reliable test. Okay. The next test is the gold standard. Latchman's test, gold standard. And if in the entrance they ask a question, best clinical test, gold standard clinical test. Okay, gold standard test. A question, something comes like that. Best test, gold standard test, most reliable, most sensitive. And question comes like that. Answer is Latchman. Answer is Latchman. What is that? You see, patient is in supine position. Knee flexed to 30 degree. Okay. Knee is just flexed to 30 degrees. Okay. See, in anterior Droyer's, you are flexed the knee to 90 degree. Here, knee is flexed only to 30 degree. The examiner places one hand behind the tibia, the thumb on the tibial tuberosity. The other hand is placed on patient's thigh. And he tries to, you look at the diagram, he tries to anteriorly translate the tibia. When the translation is more than 2 millimeters, the test is considered as positive. 2 millimeters test is considered as positive. And practically it is true, one book says Latchman test is more reliable, more sensitive, superior to anterior Droyer's. Why it is superior to anterior Droyer's? For two strong reasons. Latchman is comparatively superior to anterior Droyer's. Number one, in anterior Droyer's, you have to flex the knee to 90 degree. In Latchman, 30 degree flexion is enough. Okay. So there, 90 degree flexion is needed. Here, 30 degree flexion is enough. Why? In which way it is better? See, already the patient is having a cruciate ligament injury, acute injury. There will be pain. When you flex the knee to 90 degree, it will hurt him more. When you flex 30, it will hurt him less. So the first reason why Latchman is superior, it will hurt the patient less. Reason number one. Reason number two, no doorstep phenomena. Doorstep phenomena, as I explained no last slide, it's positive. It may be present in anterior dryas. When there is associated medial meniscal injury, especially posterior horn of medial menisci, anterior dryas may be negative. Okay, whereas Latchman will be positive. Whenever there is medial meniscal injury is associated with the ACL also, it will give you very clearly ACL is gone or not. Okay, in that way, for these two reasons, no, Latchman is superior to anterior dryas. This you should fix it in your mind. Such an important MCQ. Okay, then pivot shift test. No need to go through all these things. Pivot shift test is done for ACL. Practically speaking, we are doing only two tests in clinical thing. Anterior dryas and Latchman. Latchman is the best. Pivot, for theoretical sake, you should know pivot shift test is done to assess ACL injury. Investigation, first basically you take an X-ray. X-ray may show you two things. One, it may show a tibial eminence fracture. It may show you a tibial eminence fracture. You see, this is tibia. This is tibia. This is the tibial spine. Otherwise called tibial eminence. A fracture can happen here. A fracture can happen there. That's called tibial eminence fracture. That's called tibial eminence fracture. Okay, so that is a possibility. Number two, please record in your mind, register in your mind, Seagond fracture. Seagond, new name. Okay, Seagond fracture. Seagond fracture is an avulsion fracture of the lateral tibial plateau. It is pathognomonic of ACL tear because ACL will pull the capsule and it will cause an avulsion fracture in the lateral tibial plateau. You see this X-ray, a classical X-ray of Seagond fracture. Concentrate there, please. You see here, this is medial tibial plateau, medial eminence, lateral tibial plateau. At the end, no, plateau finishes here. You are able to see a small piece there. If I erase, easily you can see. You see? Now you are able to see a very small piece there. That is called Seagond fracture. That is called Seagond fracture. Whenever you see a Seagond fracture in X-ray, ACL is gone. Unless otherwise you read, you can't guess this type of questions, dear friends, because ACL somewhere attached here. Why a fracture should happen there? So nowadays it is image-based era. Same X-ray may come in your exam. Identify the fracture, Seagond fracture. Diagnosis, ACL tear. MRI is the investigation of choice. MRI with knee 15 degree external rotation will show the entire ACL. ACL, it shows the entire ACL. Evidence of bone contusion and edema in the lateral femoral condyle near the sulcus terminalis and posterolateral aspect of the tibia is called Kissing's lesion. Okay. Kissing lesion in MRI, ACL is gone. Kissing's ulcer, duodenal ulcer. Kissing's disease, infectious mononucleosis. Okay, all Kissing's MCQs. Coming to treatment, ACL tear, no? You just divide it into two things. Non-surgical, right? Surgical. Non-surgical, surgical. Non-surgical, basic thing, when will you do non-surgical? When it is a very partial tear. When it's a very partial tear, not a complete tear, partial tear. And otherwise patient is very old. You can try a non-surgical. If it is a complete tear and young individual, he is very active, very young individual, especially he's a sports person, you should go for surgical management. Where you can try non-surgical or conservative method in elderly individuals, otherwise in a incomplete tear or partial tear. What are the non-surgical methods that are available? Activity modification. What do you mean by activity modification? You should not have all this fast running. You should advise don't decelerate quickly. Don't have a cutting action. All these things. And you should promote hamstring exercise or hamstring strengthening exercise. Okay. When you do quadriceps exercise, quadriceps contraction, ACL will become tight. When you do hamstring exercise, ACL will relax. So you are doing an exercise by which ACL will relax. That's called hamstring tightening exercise. Otherwise called closed chain physiotherapy. This is called closed chain physiotherapy. Okay, closed chain physiotherapy. Right. Coming to surgical management, if bony avulsion is present, the avulsed fragment fixed with sutures or transosseous screw. Number 2, primary repair of ACL can be tried. What do you mean by primary repair of ACL? For example, this is from medial condyle, ACL is coming, getting attached to the lateral condyle. You just imagine this is the ACL. Okay. If there is injury either here at the insertion site or origin site, you can try suturing this. That is called suturing an anterocruciate ligament is called primary repair. Other way around, if you are having a mid-substance tear, ACL is here, okay, totally torn in the mid-substance here, you are not supposed to do a primary repair. Okay, primary repair means just suturing the ACL. That is not, it's contraindicated for a mid-substance tear. When there is mid-substance tear, the best thing is reconstruction of ACL. This is the commonest method which we follow in our hospital, which we do normally. It is usually, book also says this is the treatment of choice. Best treatment is ACL reconstruction. That is, with graft taking somewhere from the patient's own body, you are reconstructing a ACL. Okay. So it usually, the types of grafts that are the harvested are bone patellar tendon bone graft, BTB, patellar tendon graft. Otherwise, you can take semitendinosus or gracilis. This is the method which we follow. Okay. Right, semitendinosus gracilis graft. Normally, surgery is not done immediately. Theory says that it will take minimum 4 weeks. It's done 4 weeks after trauma. Practically, I am telling, okay, dear friends, for us in our setup, it takes 6 weeks. For what you are waiting, why you are waiting? Before doing ACL reconstruction, 4 things should be satisfied. Very important MCQ. What are the prerequisites for a reconstruction of ACL? Patient should have regained full range of movement of the knee. Okay, you should be able to flex fully and extend fully. Number 2, good quadriceps function. Number 3, normal gait. Number 4, last but not the least, there should not be any residual knee effusion or hemarthrosis. There should not be any residual hemarthrosis or knee effusion. Whenever there is some residual hemarthrosis or knee effusion, when you do ACL reconstruction, you'll end up in a disaster, dear friends, infection. Okay. So this is about ACL. Posterior cruciate ligament, very simple. Isolated posterior cruciate ligament injury, most of the time it is asymptomatic. Because instability caused by PCL is often very subtle, not noticeable. Okay, so mostly it's asymptomatic. Most common mechanism is direct hit from posterior aspect of the tibia. The clinical tests, posterior Dreyer's test, like anterior Dreyer's, posterior Dreyer's test will be positive. Second important peculiar test is called Godfrey's sign. Godfrey's sign is otherwise called gravity sign, otherwise called sag sign. Godfrey's sign is otherwise called gravity sign or sag sign. You look at that. You make the thing hip to 90 degree, knee to 90 degree. When you see, you see the tibia is sagging down. Like. So it's called a gravity sign, sag sign or Godfrey's sign. It says that posterior cruciate is complete tear of posterior cruciate ligament. Treatment posterior cruciate ligament reconstruction is done through tibial or femoral tunneling technique. Graft of choice is same like your anterocruciate. You are taking patellar tendon graft, quadriceps tendon graft, semimembranosus, semitendinosus or gracilis graft. Same. Okay. Once we finish this, meniscal injury. In meniscal injury, most common in adolescents and young adults, very rare in children. Most common in meniscal tear, especially traumatic, is most common in adolescents and young adults. In children, it's very, very rare because medial menisci, lateral menisci, very flimsy, very, very flexible in a child. And it's not very tight, so it won't go for damage. Okay. Meniscal tear is broadly divided into 2 types: traumatic tear, degenerative tear. Traumatic tear, the most common site of meniscus. See, there are two menisci, dear friends. Medial menisci, lateral menisci. Medial menisci is more prone for injury than lateral menisci. You should think why. Medial menisci is very tightly attached to the collateral ligaments and the capsule. Lateral menisci is not that much attached. So whenever some injury happens, no, the medial menisci is more prone. Okay. So the most common site is medial menisci. In medial menisci, especially, it's the posterior horn. So most common site of tear is posterior horn of medial menisci. Discoid menisci means degenerative menisci. It is very common in lateral menisci. So read the question very carefully. There are two types of meniscal tear: traumatic tear, degenerative tear. If they ask degenerative tear, discoid meniscus is very common in lateral menisci. If they simply ask meniscal injury is more common in medial menisci, especially posterior horn of medial menisci. And the classification system is O'Connor. It's called O'Connor classification. There are 6 types: horizontal, flap tear. So you see, horizontal, you are able to see a tear here. Horizontal tear, like a flap tear. Then bucket handle tear, like a bucket handle. See, you can just lift like that. No, it's looking like a bucket handle. So it's called bucket handle tear. A degenerative tear. This is a radial tear, longitudinal tear. The most common type is longitudinal. Most common type of meniscal tear is longitudinal. Most common site of meniscal tear is medial menisci, the two posterior horn. Then patient complains of pain in the joint line more commonly at the posteromedial part of the knee. Why? Answer is obvious. Why in the medial joint line, posteromedial aspect it is common. Posterior horn of medial menisci is commonly injured, so that's the answer. And apart from pain, meniscal injury commonly presents with what is called a mechanical symptom. That's called a mechanical symptom. What are the mechanical symptoms? While flexion and extension, patient can feel a clicking, painful clicking sound or a popping sound. Popping means like a burst, top, like that. Popping sound. Locking, more common with bucket hand, locking movements. No, locking means trucking. Sudden after flexion, no, suddenly they can't extend. That's called locking of knee. Locking of knee, very common. There are 6 types of meniscal tear. Most common tear, I said, it is longitudinal. Locking episode is more common in bucket handle. That's an MCQ. Locking is more common in bucket handle tear. And locking, dear friends, locking, I will tell you, the next page I am having a thing. Locking is divided into true locking, pseudo locking. Pseudo locking. I will show you in the next thing. I am having few DDs for that. So popping sound or locking sound, otherwise a catching sound, otherwise last but not the least, meniscal injury can give a feeling of giving away. That is instability. So these are the mechanical symptoms. So one should ask for mechanical. Apart from pain, patient can have a painful click, popping, locking, catching, giving. Differential diagnosis, as I said, no, true locking. Number 1, meniscal tear, especially bucket handle. Number 2, loose bodies in the knee joint. Loose bodies means small separate individual bony fragments. Loose bodies, very important feature of osteoarthritis, loose bodies. And loose bodies can happen in certain tumors also. Loose body commonly seen in osteoarthritis. So whenever there is loose bodies, it can cause true locking or intra-articular tumors. Okay, these are the 3 differential diagnoses. When somebody says locking, when some patient says locking episode is there, you should be able to differentiate whether that is true locking or pseudo locking. How to differentiate true locking, pseudo locking? If it is a false locking or pseudo locking is mostly due to hamstring pull or hamstring spasm. So when you give rest for 24 hours, give a good muscle relaxant, this will vanish away. When the locking vanishes away, that's called a pseudo locking, and the cause is hamstring spasm. That is pseudo locking. But a patient has true locking, 3 things should cross your mind: medial meniscal injury, loose bodies, intra-articular tumors. Okay. Then coming to clinical tests of medial meniscal injury, 2 important tests are there. One is called McMurray's test. Just The name is very important. Go through once. Step 1. Patient is in supine position. Examiner holds the knee and palpate the joint line. Other hand holds sole of the foot. Knee is kept in full flexion. Examiner applies valgus stress over the knee. The other hand and foot externally rotated. Knee is gradually extended. An audible click or pain is appreciated. That's called McMurray. Next important thing is called Apley grinding test. In McMurray test, patient is in supine position. In Apley grinding test, patient is in prone position. Put the patient in prone position. Look at the diagram. And knee is flexed to 90 degree. Patient thigh is fixed to the examination table with examiner's knee like this. Then the examiner medially and laterally rotates the tibia combined with the distraction. If there is pain associated with excessive rotation during distraction, it is ligamentous injury. In pain, at the same time, step 4, the patient medially laterally rotates by giving compression. After that, you are doing. If there is pain associated with the restriction of rotation in meniscal, during compression, it is meniscal injury. During distraction, whenever there is pain, it is ligamentous injury. During compression, there is pain, it is meniscal injury. Apley grinding test has 87% specificity, 97% sensitivity. X-ray AP lateral view done in standing position, it won't give you much. It may, if medial meniscus is totally damaged, degenerated, absorbed, it will show you narrowing of the medial joint space. That's all. MRI is the investigation of choice. MRI has 98% accuracy for medial meniscal tear and it has 90% accuracy for lateral meniscus tear. So MRI is more easily to diagnose medial meniscal tear than lateral meniscal tear. If there is any confusion, the best investigation is diagnostic arthroscopy. Since it's an invasive thing, we won't do it. MRI is the investigation of choice. Coming to treatment of meniscal injury, non-surgical, surgical. Non-surgical, incomplete meniscal tear, a small stable tear without ACL injury. Okay, a small stable tear, only pure medial meniscal tear, no ACL tear. A stable vertical tear in the red zone. You see, dear friends, meniscal, see everything in detail with pictures I had discussed in the regular recording. This is just a rapid revision. Again, no harm. A medial meniscus, no, like a semilunar cartilage. It's like this. The outermost zone is one zone. Okay. Right. Then comes the second zone. So this is the first zone. This is the second zone. This is the innermost third zone. This outermost zone is rich in blood supply. So that's called red zone. The second zone, middle zone, is less in blood supply. So that's called red-white zone. The innermost or the third zone is totally devoid of blood supply. That's called white zone. So any injury happening in red zone, since there is blood supply, there is chance of healing even with conservative methods. That is why a stable vertical tear in red zone. You can try non-surgical. If the same thing it happens in white zone, no question of non-surgical, you have to do some surgery. Right? Apart from that, where non-surgical method is contraindicated. If meniscal injury is associated with any one of the mechanical symptom, I told you, clicking sound, popping sound, locking, giving, okay, catching. So in any one of the mechanical symptom is there, you have to go for surgery, no role of conservative. This is how they will take a question. All are indications for conservative management of meniscal injury except maybe the question. Okay. Then what are the methods you can do a non-surgical treatment? Groin to ankle cylinder cast or knee immobilizer. Crutch walking without giving much weight to the knee joint. Progressive isometric exercise for quadriceps, hamstring and muscles around the knee joint. Physiotherapy. Surgical method, arthroscopic meniscal repair. Meniscal repair means suturing the meniscus. That is indicated only in vertical tear, longitudinal tear, in red zone. In red zone. Only in red zone, some small tear is there, you can try a suturing. If there is somewhere else in red-white zone or white-white zone in injury is there, you have to go for arthroscopic partial meniscectomy. It is indicated in radial, oblique, all other types. Only in vertical tear and longitudinal tear in red zone, you can do an arthroscopic repair. In all other thing, it is an indication for arthroscopic meniscectomy. Remove a partial, you do a part of meniscus. Don't remove the total meniscus. When you remove the total meniscus, one problem, one complication can happen, because meniscus is a very important thing for proprioception. So proprioception may be lost. Okay, joint sense. So leave some meniscus. That's why the word partial meniscectomy. That completes the meniscal tear. Yeah, we will see the next topic, rheumatoid arthritis. The definition itself will give you the pathogenesis. Okay, it is a chronic inflammatory disease characterized by hyperplasia of the synovium, hyperplasia of the synovial lining cells, angiogenesis, infiltration of the mononuclear cell resulting in pannus formation. Pannus is the basic and it's a hallmark of rheumatoid arthritis, which causes cartilage erosion, ultimately ending in joint destruction. Okay, so this is the definition. You read the definition fully, it will give you the pathogenesis. It is a chronic inflammatory disease characterized by hyperplasia of the synovial lining cell. Initial focus of inflammation is the synovial cell. Angiogenesis, there is new vessel formation, angiogenesis, then infiltration of mononuclear cells resulting in what is called a pannus formation. That pannus causes erosion of the cartilage and eventual joint damage. Okay, so this is the definition of rheumatoid arthritis. Most common inflammatory arthritis, most common cause of inflammatory arthritis is rheumatoid arthritis. Most common cause of degenerative arthritis is osteoarthritis. Okay, 1% of adult population is suffering from rheumatoid arthritis. Among them, 75% are women. Okay, so 3:1. Suppose 3 women are involved, only 1 male is involved. 3:1, and the peak age of incidence is 40 to 50 years. All these things can be asked as an MCQ. Have been asked already. It's not a old peak age of incidence 40 to 50 years. More commonly women. Okay, 1% adult population suffers. Coming to etiology, to be very frank, there is no clear-cut etiology. Certain things are implicated in causation. So, see, monozygotic twins exhibit concordance. HLA-DR4, 10 lakh time repeated MCQ. HLA that is associated with rheumatoid arthritis. HLA-DR4 found to be a major risk factor. Then, HLA-DW16, this is very peculiar. Okay, look at here. HLA-DR4 is the HLA for rheumatoid arthritis throughout the world. HLA-DW16, major risk factor in Asian Indians. We are more bothered about our country. Asian Indians, HLA-DW16. Suppose if in our NEET exam they ask the HLA that's associated with rheumatoid arthritis in Asian Indians or in Indians, if they ask a question, Asians, if they ask a question, HLA-DW16 is there, they are asking for that. Definitely they will give HLA-DR4 also in the choice. Should be double careful, dear friends. And certain infectious agents are cause for rheumatoid arthritis. Mycoplasma, mycobacteria, E. coli, virus like Epstein-Barr virus, cytomegalovirus, parvovirus, rubella virus. This parvo several times repeated MCQ associated with rheumatoid arthritis. HLA-DRB1, individual who smokes are at high risk of developing rheumatoid arthritis. Pathogenesis is the same thing. Increased cellularity includes synovial infiltration by beta cells, macrophages, fibroblast. Beta cells develops into plasma cells, and that produce what is called an RA factor. RA factor leading to complement activation. This leads to migration and proliferation of fibroblasts, vascular infiltration, and this causes development of a granulation tissue. That granulation tissue is called pannus. Bony and cartilage destruction appears to be caused by activation of the collagenases and other degrading enzyme. Where it is released from the pannus. Okay, so pannus releases certain collagenases and other degrading enzyme. Okay, so that causes cartilage damage and joint destruction. Okay, so you see the healthy bone, normal synovial cell, normal cartilage, normal bone. You see here synovial, okay, cell inflammation, synovial hyperplasia. Then pannus formation. This goes and damages. Clinical feature, there is symmetrical involvement of small joints of the hand and foot. And joints that are involved in decreasing frequency. This is very important slide, dear friends. Metacarpophalangeal joint is the first joint or most common joint that is involved. Next to that is wrist joint, then proximal interphalangeal joint, then knee joint, then metatarsophalangeal joint, then comes your shoulder, ankle, cervical spine, hip, elbow, last but not the least temporomandibular joint. The most common joint that is involved is metacarpophalangeal joint. Least commonly it's temporomandibular joint. When you see all these things, okay, one thing is missing. You should be able to analyze that which joint is not involved. You see, carefully analyze thing. One joint is missing. You see, the joint that is not involved is distal interphalangeal joint, sacroiliac joint. 10 lakh time repeated MCQ. Rheumatoid arthritis involves all joint except distal interphalangeal joint. Okay, sacroiliac joint. In vertebral column, only cervical spine is involved. When somebody complains of backache, a lumbar backache, low backache, okay, definitely it is not rheumatoid arthritis. You are missing some other diagnosis, dear friends, because it will never involve lumbar or thoracic. If at all a spine is involved, only cervical spine is involved. Okay, right. And the patient can present to you with rheumatoid nodules. Rheumatoid nodules are present only in 25% of cases, and a study says it's more common in Western world than Indians, and it is seen only in extensor aspect. Extensor aspect means not in the olecranon, very classical thing, olecranon aspect of the elbow, over the tendo-Achilles, extensor aspect of the hand and foot. You see this? Okay, these are rheumatoid nodules. So they are seen only 25. One very interesting thing they have found out in clinical practice. You know pretty well one drug which is very commonly used in rheumatoid arthritis is methotrexate. When you give methotrexate in some patients, it increases the size of the rheumatoid nodules. So that's why they are using a word, increase nodulosis. Increased nodulosis means it increases the size of the rheumatoid nodules. Kaplan syndrome, Felty syndrome. You should be able to differentiate what is Kaplan syndrome, what is Felty syndrome. Kaplan syndrome is rheumatoid arthritis with co-locus pneumoconiosis is called Kaplan syndrome. If it is rheumatoid arthritis plus splenomegaly plus neutropenia, right? Kaplan syndrome is rheumatoid arthritis is co-locus pneumoconiosis. Felty syndrome is rheumatoid arthritis plus splenomegaly plus neutropenia. It's called Felty syndrome. So symptoms of rheumatoid arthritis will improve with pregnancy, right? This is true for all autoimmune disorders. All autoimmune disorders improves with pregnancy. What are the typical deformities? Just I will name the deformity, I will show you the picture and I will go. Okay, no need to explain because very thoroughly explained in the main recording. Swan neck deformity of the distal phalanx, Botanius deformity of proximal interphalangeal joint, hitchhiker's deformity, the thumb, Z deformity of metacarpophalangeal joint, main and lorgnette deformity, others called telescoping fingers, a windswept deformity in the lower limb, torchlight deformity or daylight deformity of the foot, sudden onset flat foot, very peculiar. Sudden onset flat foot. They was not having flat foot. Normal arch was there. Suddenly going for a flat foot in the middle age, 40 or 50, think of rheumatoid arthritis. A protrusio stabile of the hip. Then Baker's cyst. You see, classical windswept deformity. You see, genu valgum on one leg, on one knee, genu varum on another knee. This is called windswept deformity. Then you see this Botanius deformity of proximal interphalangeal joint, swan neck deformity of the distal phalanx. You see here, you see Z deformity. You see like this. Sir, no. So this is Z deformity of the hand. Ulnar deviation of the metacarpophalangeal joint. Okay, Z deformity. This is Z deformity. So these are classical deformities. One should not. These names are very important, dear friends. All are asked question. Kindly, this is a rapid revision. Just revise it. You want a detailed discussion? Just go and watch the main video. Swan neck deformity, Botanier deformity, other is called buttonhole deformity, hitchhiker's deformity, Z deformity, telescopic fingers, windswept deformity, torchlight deformity, sudden onset flat foot, protrusio stabile, and Baker's cyst. Coming to diagnostic criteria, this is very important. This is 2023, but the latest diagnostic criteria is 1987 American College of Rheumatology revised criteria. This is the latest. This is the criteria which is followed throughout the world. Okay. All these things should be there for a period of 6 weeks. That's very important. If they are having the symptoms for 1 or 2 weeks, it is not rheumatoid. It should be there for 6 weeks clinically. And early morning stiffness of the hand joints. Early morning stiffness for more than 1 hour for 6 weeks. Arthritis of 3 or more areas. More than, see, hand means another elbow, knee, like that. Different areas. Arthritis of 3 or more areas. Arthritis of hand joints. Symmetrical joint involvement. Rheumatoid nodule. Positive rheumatoid factor. Subcutaneous, then positive radial subcutaneous nodule is this rheumatoid nodule. You can strike out this. In the 7th, it is positive radiological features. I repeat once again, there are 7 points are there. Number 1, early morning stiffness for more than 1 hour, especially hand joint. Arthritis involving 2 or 3 areas, different areas. Hand joint involvement. Symmetrical joint. What do you mean by symmetrical joint involvement? For example, my left index finger is involved, right index finger also should be involved. That's called symmetrical joint involvement. Rheumatoid nodule, positive rheumatoid factor, positive radiological signs. 7 things are there. When it is said to be positive, 4 out of 7 points are there, 4 points are present for a period of 6 weeks. Clinically, you can diagnose that's a case of rheumatoid arthritis, and this is called 1987 American College of Rheumatology revised criteria. Classical radiological features, you see, look at here, dear friends. This is your fibula. Okay, this is your fibula. So this should be the lateral side. This should be the lateral side. This should be the medial side. Okay, you see the joint line. You just see the joint line. Joint space narrowing is there. Equal on medial side, equal on lateral side. So you see, now you see very easily you can sense that symmetrical joint space narrowing. Diagnosis rheumatoid arthritis. If it is asymmetrical joint space narrowing, it is osteoarthritis. Symmetrical joint space narrowing, it is rheumatoid arthritis. Marginal and central articular erosion is the earliest bony change. That is, this is marginal, this is central. Bony erosion is the earliest articular change. Periarticular, just around the articular surface, it will go for osteoporosis. Periarticular osteoporosis is a feature. Soft tissue swelling. If you see the X-ray, don't think it will show only the bone. When you have a good X-ray and a good eye, you can see the soft tissues also. Soft tissue swelling will be there. And book says that's the earliest thing of rheumatoid arthritis. Radiological feature, earliest thing is soft tissue swelling. Right? Symmetrical joint space narrowing, marginal and central articular erosion, periarticular osteoporosis. So these are the classical radiological signs of rheumatoid arthritis. Then coming to lab investigation, anti-citrullinated cyclical peptide can be positive in early stages and has prognostic importance. Rheumatoid factor positive only in 60%. False positive rheumatoid factor is possible in cryoglobulinemia, Parvo B19 infection, hepatitis C, Sjogren syndrome, SLE, and even in 5% of normal individuals. Okay, so rheumatoid factor is a good investigation, not an excellent investigation. So the best investigation or investigation of choice is anti-CCP. That's the point I want to stress. And positive ANA can be there in 40%, elevated ESR and C-reactive protein. So normally what we do for assessing the prognosis, whenever patient coming for regular checkup, monthly checkup, we will repeat 2 things, ESR and C-reactive protein. That's of great importance in prognosis. ESR should come down, C-reactive protein should become negative, then only it says the disease is not active. Anti-citrullinated cyclical peptide, anti-CCP, is very useful in confirming the diagnosis. Okay, right. If they ask a question, investigation of choice, it is you should go for anti-CCP. Rheumatoid factor is positive only in 60%. It has lot of conditions. There are 6 conditions where you will get false negative. One more thing, 7th also you can add here. You see, cryoglobulinemia, Parvo, hepatitis C, Sjogren, SLE, 5% normal individuals. 7th you can put an add, malaria. Malaria is also, it is false positive. Refer your general medicine book, it is given. Rheumatoid factor is positive in malaria individuals. Okay. Coming to treatment of rheumatoid arthritis, in acute stage, and the patient is having severe swelling, pain, all those things, where the rheumatoid is frank inflammation is there, put the patient on corticosteroids for a short period of 1 to 2 weeks. It's the drug of choice, corticosteroids. After that, to knock down the disease, you have to start on disease modifying anti-rheumatoid drugs. Drugs that are used are hydroxychloroquine, 200 milligrams twice daily, BD dose for few months. Sulfasalazine, methotrexate is usually given 7.5 milligrams weekly once. Okay, and leflunomide. So these are the drugs that are tried, DMARDs. If it is not acting to DMARDs, you have to go for biological agents. Biological agents will always end up with MAB. You see MAB. MAB stands for monoclonal antibody. That's why it's called biological agents. Infliximab, etanercept, adalimumab, golimumab, anakinra, tocilizumab. So these are the drugs, and tocilizumab is coming up like anything. Our country is India, and we are very prone for tuberculosis. That everyone knows that tuberculosis. Okay. So tuberculosis, most of us may be having a hidden or subclinical tuberculosis. When you put these biological agents, they are very severely immunosuppressive agents. Biological agents is severely immunosuppressive agents. So what happens? It will cause flare-up of tuberculosis. So that's the problem. Okay, it causes flare-up of tuberculosis. So before starting biological agents, make sure that this guy is not having any subclinical tuberculosis. So it's a contraindication. So these are the drugs that are tried. But once for example, knee joint totally damaged, okay, articular surface, everything is gone, damaged. The final thing, it will come to us, orthopedic surgeon. So far, it's only for physicians. After once the joint got damaged for correction, it will come to, for example, totally the knee joint is damaged. You just assess whether the disease is active or not. If the disease is not active, you can go ahead with total knee replacement. Okay, surgical correction, joint replacement, total knee replacement. That to some extent completes the rheumatoid arthritis. We'll go to the next topic, osteoarthritis. Osteoarthritis, it is the most common degenerative joint disorders. Osteoarthritis. See, arthritis means inflammation should be there. This is not an inflammatory condition. It's a degenerative condition. So the word osteoarthrosis is the best thing. So it is divided into two types, primary, secondary osteoarthrosis. Primary means primary osteoarthritis is articular degeneration without any underlying cause. Secondary osteoarthritis is consequence of pre-existing abnormality. Already in the knee, for example, pre-existing abnormality is there. Maybe a rheumatoid, maybe tuberculosis or septic arthritis. Okay, so some pre-existing pathology is there. Then patient, because of that, the joint congruity, the alignment is lost. So the knee gets damaged in developing osteoarthritis. That's called secondary. But to our knowledge, the most common cause of osteoarthritis, the type of osteoarthritis, primary. Okay. Pathogenesis, very simple pathogenesis. Earliest thing that is happening is increase in water content of the cartilage. There is increase in water content of the cartilage. Increase in water content of the cartilage, what it causes? Progressive softening and disintegration of the articular cartilage associated with new growth of cartilage and bone. That's called osteophyte at the joint margins. Okay, this is the pathogenesis. Right, increased stress, that is obesity, otherwise overactivity, excessive usage of a joint. That's the most common precursor of primary osteoarthritis. Earliest symptom is pain, and the most distressing symptom is loss of function. In very severe cases, because of loose bodies and totally the joint space, everything is narrowed, patient can't flex or extend the knee. That is the worst distressing symptom. But the earliest thing is always pain. And patient can have what's called the hand signs of osteoarthritis. They can have what's called a Bouchard's nodule or Herberdon's nodule. Bouchard's nodule, you see a nodule or bulge in the proximal interphalangeal joint. Bouchard's nodule means proximal interphalangeal joint. Okay. Herberdon's nodule, same thing in the distal interphalangeal joint. Right. If there is a swelling in the proximal interphalangeal joint, it's called Bouchard's nodule. If there is a swelling in the distal interphalangeal joint, it's called a Herberdon's nodule. So it's not, you should think it is not inflammatory. It is just a degenerative change. Look at the real time. You're able to see a bulge here. Okay. So this is in the proximal interphalangeal joint. This is a Bouchard's. Here I am able to see a bulge in the distal interphalangeal joint. This is a Herberdon's. So this is Bouchard's. This is Herberdon's. Okay, Herberdon's, right? You see, and two special types of osteoarthritis Apley is giving, New Robbins is giving, Cashin-Beck osteoarthritis. Osteoarthritis, so far we know it's caused by increased stress if it is primary, or if there is any pre-existing tuberculosis or septic arthritis or some other thing, it is secondary. Now they have found out when you consume mycotoxin, that is fungal toxin, for quite some time, it is inducing osteoarthritis of the knee. So they had found out, where in cold countries like Russia, Denmark, all these countries, their staple food is wheat bread. They will store the wheat bread for a very long time. That bread gets infested with mycotoxin. When a person consumes that for a very long time, what happens? It is inducing osteoarthritis of a joint, and that's called Cashin-Beck's osteoarthritis. New entity. Dear friends, they may ask a question in NEET like this: Cashin-Beck's osteoarthritis is due to fungal, bacterial, viral, protozoal. Should you say it's fungal? Then MSELENI, it's called, M is silent, pronounced as Seleni osteoarthritis. Seleni osteoarthritis. Hip is more affected and it is genetically determined. It is genetically determined. Seleni's osteoarthritis, genetically determined. Hip, okay, transmitted in family. Primary osteoarthritis of the hip, which is transmitted genetically, is called Seleni. This is again a new entity. And coming to X-ray features, you see in osteoarthritis we had seen symmetrical joint space narrowing. Here you see this is lateral side, the joint space is narrow, medial side it is okay. So this is called asymmetrical joint space narrowing. This is called asymmetrical joint space narrowing. Whenever a word in your radiology or ortho MCQ, symmetrical joint space narrowing, diagnosis is rheumatoid arthritis. Asymmetrical joint space narrowing, the diagnosis is osteoarthritis. And there is sclerosis of the subchondral bone. There is, you're able to see white color, the sclerosis of the subchondral bone, and cyst in the joint surface, osteophytes, hook-like thing, that the excessive growth. Here you see a beautiful, a real X-ray. You see here a hook-like thing here, that is called osteophyte. That's called osteophyte. So asymmetrical joint space narrowing, sclerosis of the subchondral bone, cyst in the joint, and osteophytes at the margins. Classical radiological finding. Coming to treatment of osteoarthritis, non-surgical, surgical. Non-surgical, patient education physical therapy. They give hot fomentation for 20 minutes during bedtime regularly. What does it? It increases the blood circulation, increase the blood supply, try to increase the synovial fluid. Weight loss, then knee bracing, non-steroidal anti-inflammatory drug. See, in this, Harrison says that paracetamol is the drug of choice. Okay, paracetamol is the drug of choice for osteoarthritis. Because why your dichloraciclo is not recommended? Because diclofenac sodium, good NSAID, but it can go and damage the cartilage. Already in osteoarthritis there is articular cartilage damage, so paracetamol is preferred. And you can, of course, try intra-articular injection of steroids. Okay, two things can be injected: intra-articular injection of steroids. Okay, intra-articular steroids like Depopred, or you can induce what's called Hylase, hyaluronic acid. Okay, can induce hyaluronic acid into that joint. It acts like an artificial synovial fluid so that it will reduce the friction. Both these practically has good results. You can postpone surgery, okay? But all these things can be tried for mild to moderate osteoarthritis. If osteoarthritis is very severe, totally the joint space is narrowed, no, you can't try all these things. You have to go for what's called surgical management. Surgical management, two surgeries are available. One is called HTO, stands for high tibial osteotomy. HTO stands for high tibial osteotomy. Okay, high tibial osteotomy. Right. So high tibial osteotomy, what do you mean by that? For example, only the medial component, I will show you this picture. You see here. Here, this component is okay. The joint space is okay. This is narrowed. This is narrowed. So what I will do, I will take a wedge of bone here. I will take a small piece of bone and will compress this so that joint line will be maintained. I am widening the joint line by taking a wedge from the uppermost portion of the tibia. That's called high tibial osteotomy. So high tibial osteotomy is indicated only in unicompartmental OA. That is either purely medial compartment is involved or lateral compartment. If medial, lateral, both compartments are involved, then high tibial osteotomy is useless. Very severe OA, you have to go for what is called TKA. TKA is otherwise called TKR, total knee replacement, joint replacement. Okay, so that's the option. Okay, so that completes the topic osteoarthritis.